Hello, everyone, and welcome to our program, In a Nutshell, Endometrial Cancer Molecular Subtypes. I'm Kitty Silverman, the Uterine Cancer Program Director at SHARE. Before the program begins, I'd like to tell you a little bit about SHARE. We're a national nonprofit that supports, educates, and empowers anyone who has been diagnosed with breast or gynecologic cancers and provides outreach to the general public about signs and symptoms. Now I'd like to hand it over to today's speaker, Dr. Myers, to introduce herself.
Hi, good afternoon. I'm Tashanna Myers. I'm the Chief of Gynecologic Oncology at Bay State Health in Springfield, Massachusetts.
Thanks so much for joining us, Dr. Myers. I'd like to start off by asking you to give a short overview of the molecular classifications shown on the slide, and then I'll follow up by asking you a few more specific questions.
Absolutely. So in this slide, I go over the molecular classification for endometrial cancer. Broadly, there are 4 categories in which the majority of tumors will fall into. The first column is POL mutated, and this prognosis tends to be the best. The potential alterations in treatment can be a de-escalation or no adjuvant treatment. These patients tend to be a little bit thinner, have earlier stage, and predominantly endometrioid histology in all the grades from 1 to 3. We typically will identify this through next generation sequencing. Category 2 would be MSI high. These are also called MSI hypermutated. The prognosis is intermediate, and the potential treatment options would be immunotherapy or PD-L1 inhibitors. Clinically, these patients will have Lynch syndrome, which is an inherited syndrome. Histologic subtypes, again, endometrioid histology, predominantly grades 1 through 3. And this can be diagnosed in 2 ways, IHC, immunohistochemistry, or by next generation sequencing. The third category, NSMP, is probably represents more than 50% of our patients, and it's no specific molecular profile. So essentially, these are the patients that have the absence of the other categories. It's intermediate prognosis and higher BMI in these patients, estrogen receptor positive, predominantly low-grade endometrioid. And then really it's a diagnosis of exclusion. And then P53 abnormal, unfortunately has a slightly worse prognosis, and the potential treatment options include chemotherapy or targeted therapies. These patients are going to be lower, have a lower BMI, and present at later stage. And these histologies are going to be really more aggressive. So grade 3 endometrioid, carcinosarc, serous clear cells. Our diagnostic tests are going to include immunohistochemistry and next-gen sequencing.
Thank you very much. That was terrific. My first question actually is, how and when did these classifications start getting used, and what has the overall significance been in regard to endometrial cancer treatment?
Right, so it's a really exciting time in endometrial cancer. So this data was first published in 2013. The Cancer Genome Atlas reported this molecular multi-platform assessment. There were about 370 endometrial cancers, 300 of which were endometrioid, and about 60 were serous tumors. And they did a combination of whole genome and exome sequencing, microsatellite instability, copy number analysis, and they essentially created the second line of this chart, this TCGA category. So all of the tumors fell into these 4 categories. And then a few years later, 2 groups independently said, how do we apply this clinically? And came up with a molecular classification. And so the PROMISE algorithm, and that stands for Proactive Molecular Risk Classification Classifier for Endometrial Cancer. And so while the categories are not identically identified, they really did align. And we're now further using this in 2023, we changed the staging to incorporate this molecular classification. So I say we are really moving to use this data clinically and to try to improve outcomes.
Was that the change in the FIGO staging?
Correct.
Oh, okay.
Correct.
And that really, a lot of that was related to including this.
Yes, the main changes are going to be the incorporation of this molecular platform.
Great, that's interesting. Yeah. I think you touched a little on the testing, but what testing is used to determine these molecular classifications, and at what point after the cancer diagnosis do you give these tests?
So we're really aiming to have these tests performed at the time of diagnosis. So it can either happen on a biopsy specimen, those specimens tend to be small, or at the time of surgery. The testing can be performed in two ways. So immunohistochemistry is the simplest form, and as well as next generation sequencing. So those are the two main modalities. And what it's helping to guide us is to help to put people into different prognostic categories. Now, it's not fully ready for prime time, but we are at least beginning to recognize that there are some tumors that may inherently have a better prognosis and maybe have the opportunity to decrease the aggressiveness of therapy we offer.
Thank you. Actually, that leads well into this next question. What's the difference between the next generation sequencing and immunohistochemistry, and what's the standard of care as to, when they are used?
So immunohistochemistry is essentially using antibodies to map to certain antigens and then quantify the expression of those antigens. It's in most hospitals very standard, very routine, and 3 of the categories can be determined with that testing. So the MSI high, and the P53, and obviously if you have the absence, you fall into the NSMP category. Whole mutation has been identified using next-gen sequencing. It's not as widely available, which can be a challenge for depending on where you get your care, but it is widely available through next-generation sequencing. So at our institution, we will primarily do the IHC on the MSI and the P53 and estrogen receptor. And for those patients who were really contemplating the aggressiveness of therapy, then we will send next generation sequencing. Next generation sequencing is actually looking at the sequence of DNA or RNA to study the genetic variations or mutations in the tumor. And so essentially you can map thousands of genes all at the same time with a small amount of tumor and figure out what are the mutations that your particular tumor are expressing that could serve as potential targets. Most times in clinical practice, we're doing that in the recurrent setting and not upfront. But for patients who present with more advanced stage or more aggressive histologies, we really recommend doing it earlier so that you can optimize the therapies.
Thank you. Actually, that leads into another question. If a person's cancer recurs, is it possible that their molecular classification could change?
So that's interesting. I think we don't know yet. There are times when the duration of time between the initial diagnosis and the recurrence are so far that you're going to get a new tissue biopsy, and ideally studying that new tumor that has recurred. But we don't know if what the percentage of change that happens over time. So it is an interesting question. I think there are times when we do it, if you have enough tumor, that it's not unreasonable to consider reprofiling the tumor to see if the biology has changed. Because then these are cancers, they're unregulated in how they multiply. And so genetic variations are highly probable.
Thank you. Many of our participants have heard of copy number low, P53 wild type, and P53 mutation. However, they're often confused about the differences between these two. Can you spend a little time explaining those differences, please?
So P53 wild type applies to the P53 gene in its natural or non-mutated state. So that's the normal, I guess, healthy version of the gene. A mutation in P53 signifies some alteration along that gene's mechanism, and in endometrial cancer is a marker of poor prognosis. So when we say wild type, it is your natural unmutated state.
Okay, thank you. I know that the NSMP, no specific molecular profile category, includes the P53 wild type mutation and copy number low cancers. Does this category also include hormone receptor positive cancers with PIK3CA mutations?
Yeah, so this category represents greater than 50% of endometrial cancers, right? So it's not a small number of patients that don't fall into these other categories. The tumors tend to be estrogen driven. They tend to be low grade. However, there also are aggressive cell types that can fall into this category. So those can be your clear cells, your dedifferentiated, your mesonephric-like carcinomas. Currently, the guidelines don't integrate the we don't necessarily modify your treatment directly by your molecular subtype. We're still relying heavily on pathologic features. So we're learning what is the level at which we can use this information to truly optimize patient care. And then in terms of the PIK3C pathway, yes, this pathway is highly active in this category of patients with the low mutation burden. PIK3CA it tends to be upregulated.
Have you seen a change of, I know there are new treatments that have come out, especially in the last few years. Do you see that evolving over the years with each of these categories? Hopefully, to include some more, really good treatments.
I really think this is an exciting time for endometrial cancer where precision medicine is going to really be refined and be at its best. I think the idea of just saying you have a grade 1 endometrioid adenocarcinoma is really behind us. The terminology should be you have a grade 1 MSI high, POL, mutated P53 wild type, right? The nomenclature for how we identify these tumors is really evolving. And therefore, as we get more defined in the tumors, I think we'll be able to then target our therapies appropriately. So yes, I think there's ongoing research now looking at using the molecular classification as a triaging method for therapy. And I think, again, we're just beginning to see how we can maximize that. And what's the interplay? What is the interplay of a P53 abnormal and a POL mutated tumor, right? How do those two balance each other and what becomes the driver? So I think, yeah, we should anticipate that there will be many things coming down the pike very shortly.
That's great to hear. Excellent. So I think we just have like 1 minute. So if there's anything else, Dr. Myers, that you would like to add that we haven't covered, please do. And yeah.
I think it's important to ask these questions beyond your grade and stage. The next question should be, and what is the molecular classification of my endometrial cancer? Because that really is the language that we're now speaking.
That makes a lot of sense. That's great. Well, thank you so much. This is really informative and interesting and helpful. For more information about SHARE's upcoming educational programs, support groups, and helplines, please visit our website at sharecancersupport.org. And thank you so much, Dr. Myers, for joining us today. This concludes our program. And thank you so much to everyone who joined in, and have a great rest of the day.
Thank you.